Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. So in this session, I'll be discussing the previous year questions in UPSC exam related to the topic of pulmonology in general medicine. So the questions are mainly concentrated on the very important topics like bronchial asthma, COPD, bronchiectasis, obstructive sleep apnea, bronchogenic carcinoma, then interstitial lung diseases, and the tropical pulmonary eosinophilia or the eosinophilic lung pathologies. So these are the topics in which the questions of previous years are mainly concentrated. So please try to revise these topics thoroughly just before going to the exam, right? Having said that, the first question in the pulmonology is, which of the following are categorized under the obstructive lung diseases? Bronchial asthma, bronchiectasis, bronchiolitis, the pulmonary sarcoidosis. Select the correct answer using the code given below. So, bronchial asthma is an obstructive lung disease, bronchiectasis is also an obstructive lung disease, bronchiolitis is also an obstructive lung disease, but not the pulmonary sarcoidosis. Pulmonary sarcoidosis, it is a restrictive lung disease. So, the answer should be with the code 1, 2 and as well as 3. Now, let me just give you the examples of the various obstructive and as well as the restrictive lung diseases. So, the obstructive lung diseases, just please remember the mnemonic, that is A, B square, C square, right? In the sense like the disorders with B 2 and disorders with C 2 times. So, A is your asthma, then B is bronchiectasis, and the next important is bronchiolitis. This bronchiolitis, this is very common in children, and C stands for cystic fibrosis, and another C is COPD, chronic obstructive pulmonary disease. And in the chronic obstructive pulmonary disease, we have two important subtypes, that is emphysema and chronic bronchitis. Both of them, they come under your obstructive lung diseases, right? Then coming to the examples of the restrictive lung diseases. The examples of restrictive lung diseases, they include number 1, sarcoidosis, then pneumoconiosis, right? Then interstitial lung disease, and next what we have is drug-induced fibrosis, right? Drug-induced fibrosis of the lung. Now, what are the drugs that will induce the fibrosis is, we have the important drugs like the amiodarone, right? And the next important drug will be bleomycin. So these are the pulmonary pathologies which will be causing restrictive lung diseases. And apart from pulmonary pathologies, we have some extra pulmonary pathologies also which will be causing restrictive lung diseases. And these extra pulmonary pathologies, they include obesity, spinal cord disorders like kyphosis or kyphoscoliosis, then connective tissue disorders like the ankylosing spondylitis, where the individuals will have mainly the upper lobe fibrosis, or like the other important pathology will be like there will be complete fusion of the vertebra and thereby the entire rib cage will not expand, resulting in restrictive lung diseases. Then cervical spine injury, okay, and that too, which part of the cervical spine should have been injured? It is the high cervical spine injury, where the injury, if it is at the level of C2, C3 and as well as C4, because that is a place where the root value of the phrenic nerve originates and it will supply to the diaphragm. So even in case of the diaphragmatic palsy, the individual will have the restrictive lung diseases. Then followed by that, next important conditions will be the disorders related to the neuromuscular junction or the respiratory muscle pathologies like motor neuron disease, then myasthenia gravis, Guillain-Barré syndrome. So in all these conditions, either the pathology is at the neuromuscular junction or directly within the respiratory muscles. And next important is muscular dystrophies. So these are all the extra parenchymal or extra pulmonary pathologies causing the restrictive lung diseases, right? Now, having said about the obstructive and restrictive lung diseases, I will take up the discussion in detail about one important obstructive lung disease, that is the bronchiectasis. So bronchiectasis, as I have said, it is an obstructive lung disease and it is a disorder of the medium-sized airways. Now in these patients what will happen is there will be abnormal permanent dilatation of the airways, right? Abnormal permanent dilatation of the airways. And this particular dilatation of the airways, right, it should be more than 2 millimeters. The dilatation of the airways should be more than 2 millimeters. And which particular airways are affected? It is the medium-sized airways of 5th to 9th generation. They are commonly affected, right? So we have totally 23 generation of the airways. So out of which the 5th to 9th generation is abnormally irreversibly dilated in patients with the bronchiectasis. And the most common cause of the bronchiectasis that includes recurrent infection, right? That includes the recurrent infection, right? And the next important condition will be pulmonary tuberculosis. These are the common causes. Now, apart from these, like the obstruction within the airways in the form of the mucus plug, right, or in the form of the malignancy, that even can cause bronchiectasis. And we have a congenital disorder, that is the 𝐒𝐻𝐵𝐞 syndrome, right? So 𝐒𝐻𝐵𝐞 syndrome, it is an immotile cilia syndrome. And what are the components of the 𝐒𝐻𝐵𝐞 syndrome? The components of the 𝐒𝐻𝐵𝐞 syndrome, it includes the 4 important components. Just remember that in the form of a mnemonic, that is RIBS. That includes rhinosinusitis, then infertility. B stands for bronchiectasis, that topic what we are discussing now. S stands for the situs inversus. Okay, so these are the components of 𝐒𝐻𝐵𝐞, and one of the important component of 𝐒𝐻𝐵𝐞 will be the bronchiectasis. And the other conditions which can cause bronchiectasis will be the alpha-1 antitrypsin deficiency. And then we have some congenital causes like Young syndrome, even that can cause the bronchiectasis. And what is the most common lobe which is commonly affected in bronchiectasis is, it is the left lower lobe. Why? Because the bronchus to the left lower lobe, it is longer and narrower. So that is the one which is commonly affected. And followed by that, the next important lobe that will be affected is the right middle lobe, is the one which is commonly affected in patients with the bronchiectasis. Now, this bronchiectasis, like abnormal permanent dilatation of the airways, depending upon the shape of the abnormally dilated bronchi, we have the 3 important types of the bronchiectasis. These 3 important types of bronchiectasis, this includes the cylindrical bronchiectasis. Second, like we have the saccular or the cystic bronchiectasis, right? And third important is the varicose bronchiectasis. Okay, so cylindrical, saccular and varicose bronchiectasis. So this saccular bronchiectasis is also nothing but cystic bronchiectasis. And out of all these, the most common cause for bronchiectasis will be the cylindrical bronchiectasis. So this will be the most common form of bronchiectasis. Now, what is the classical clinical presentation in these patients is, they will have cough with copious expectoration, right? So there will be increased quantity of the sputum. That is a common clinical manifestation that you come across. And the other important clinical manifestation that you can have is, because of abnormal irreversible dilatation of the airways by more than 2 mm, the bronchial vasculature which are passing over the bronchi, they can rupture, and that can cause the hemoptysis, right? So another important complication will be the hemoptysis, right? Then followed by this, dyspnea can be another important manifestation, because the airways are completely plugged with the mucus plugs. So the passage of the air does not occur, and thereby these individuals will have the dyspnea. And on examination, these patients, they will have clubbing, and they'll have the crepitations, and that will be leathery crepitations, right? They'll have this leathery crepitations. So this will be on examination. And we have a terminology called bronchiectasis sicca. Bronchiectasis sicca, this is nothing but dry bronchiectasis. That means you don't have any sputum production at all, even though there is a bronchiectatic picture. Normally in bronchiectasis, there should be a copious expectoration. But here, there is no sputum production at all. That is called bronchiectasis sicca. And that can be seen in some of the variants of the pulmonary tuberculosis. Then we have a terminology called Brooks syndrome in case of bronchiectasis. So that is right mid-lobe bronchiectasis is what is called as the Brooks syndrome, and this is also observed in case of the pulmonary tuberculosis. Then you need to know the etiologies of upper lobe, middle lobe, and as well as lower lung bronchiectasis. The upper lobe bronchiectasis, this is very common in case of the tuberculosis, and apart from that, the other conditions include cystic fibrosis, allergic bronchopulmonary aspergillosis, and then the post-radiation fibrosis. Right, post-radiation fibrosis. So these are the causes for upper lobe bronchiectasis. Then what are the conditions which will cause mid-lung bronchiectasis? Mid-lung bronchiectasis, this is very common in Mycobacterium avium intracellular infection, and then immotile cilia syndrome. And what is this immotile cilia syndrome? That is Cartagener's. So in case of Cartagener's, the lobe which is commonly affected is the mid-lobe or mid-lung bronchiectasis. And what are the conditions where you will have lower lung bronchiectasis is in patients with chronic recurrent aspiration. Right, chronic recurrent aspiration. So these are the conditions where you will have the lower lobe bronchiectasis, right? And even in recurrent immunodeficiency associated infections, you have lower lobe bronchiectasis. Then followed by that, you need to know the workup in patients with the bronchiectasis. One important is the chest x-ray. So what does the chest x-ray shows is they'll have this classical tram track appearance, because I'll show you the x-ray. The airway, it is abnormally irreversibly dilated by more than 2 mm. This dilated airway and the C-shaped cartilaginous rings, it appears like a tram track appearance, okay? And the HRCT is considered as the investigation of the choice, right? HRCT is the investigation of choice. And when you collect the sputum, because these patients with bronchiectasis, they'll have copious amount of sputum production. You collect the sputum and you place it in a flask. And the entire sputum will be deposited in 3 layers. The upper layer will be completely the foam. The mid part of the sputum, it is the mucopurulent material, right? Mucopurulent material. And the lower part of the flask, it is completely the sediment or completely thick pus will be there in the lower part of the sputum. So you just collect the sputum and place it bedside. The sputum completely gets segregated into these 3 layers, right? And bronchoscopy, it is useful for visualizing the abnormally irreversibly dilated bronchus. That is one point. And second important is the bronchoscopy is also useful for planning for the surgery. Bronchoscopy is also useful for planning for the surgical treatment in case of the bronchiectasis. Now coming to the treatment that you have to do, and HRCT, I said you investigation of choice. What will be the appearance? So the classical appearance, right? We have the signet ring appearance. That is one important feature in the HRCT. And the other one is the tree in bud appearance, right? Tree in bud appearance. Then if you take the treatment in patients with the bronchiectasis, the treatment is that you need to treat the sputum what is being produced, because the sputum which is being produced is a thick sputum, right? So you need to liquefy the sputum and you need to ensure that the entire sputum is completely expectorated out. So for that reason, you need to give 3% saline nebulization. So hypertonic saline nebulization is the one which will liquefy the sputum and the sputum is completely expectorated out. The other one is you also need to do a chest physiotherapy. Again, the same reason. The reason for chest physiotherapy is once you do the chest physiotherapy, whatever the mucus which is there within the airway, it enters into the central part of the airways, that is the main bronchus, and that is expectorated out. So that chest physiotherapy is very, very important part of the treatment, right? And the next important part of the treatment is you need to give the broad spectrum antibiotic. Why? Because it is the recurrent infections which are the most common cause for bronchiectasis. So you need to give broad spectrum antibiotics, or you need to give antibiotics according to the sputum culture and sensitivity. Now, these patients, one of the very important complications is massive hemoptysis. And why is that? That is due to rupture of the vessels which are passing over the bronchi. And once there is massive hemoptysis, you need to do the embolization. So you need to send embolic plug, right? Or you need to place a mucus plug, right? So mucus plug or embolic plug, that has to be sent into the bronchial vessels, and that plug has to close that particular rent or the ruptured site so that the hemoptysis will stop. And surgical treatment is that you can do lobectomy. But when is that you will do lobectomy is when bronchiectasis is confined to one lobe, then you need to do lobectomy, right? And if the bronchiectasis, if it is like diffuse and bilateral bronchiectasis, in such case you need to plan for the lung transplantation, right? So this is about the bronchiectasis, and let me show you the images related to the bronchiectasis. So I said you, it is the medium-sized airways which are commonly affected, that is around 5th to 9th generation in bronchiectasis. And the next important is the bronchoscopy is the one which will show you the abnormally reversible dilated bronchi and their respective shapes, that is cylindrical, saccular, and as well as the cystic. The most common is what? That is cylindrical bronchiectasis. Investigations is like 3-layered sputum, right? 3-layered sputum, okay? That is what you will observe in bronchiectasis. And chest x-ray, it will give you an appearance of what is called tram track appearance. So these airways, they are like abnormally irreversibly dilated. And how much they are dilated? They are dilated by more than 2 mm. And within this abnormally dilated airways, you have this classical tram track appearance where you have the presence of C-shaped cartilaginous rings, right? And this is what is nothing but tree in bud appearance. So in case of cystic bronchiectasis, you get this tree in bud appearance. The other one is the signet ring sign, right? So what is that signet ring sign? The abnormally irreversibly dilated bronchi, in that the mid portion is the air, and this is the mucus plug, right? So this is the mucus plug. So this will give you the classical signet ring sign. Then bronchoscopy is the one which will help us in visualizing the bronchus, and it will also help us in treating the patient with the bronchiectasis. So this completes the discussion of the first question with the brief discussion related to bronchiectasis. So the second question for the discussion is mainly on the COPD topic. Risk factors for the development of COPD includes which of the following? Tobacco smoking, recurrent infection, chronic dust exposure, high socioeconomic status. So tobacco smoking, that is one of the most common risk factor for the development of COPD. Recurrent infection is also the risk factor, and even the coal dust exposure is also one of the risk factor for the development of COPD, but not the high socio-economic status. So the correct answer here is 1, 2, and as well as 3. So now in this question, let me just give you a brief quick recap of the topic of COPD, that is the chronic obstructive pulmonary disease. So like if you take the risk factors first, as I have said you, the most common risk factor is what? That is the smoking. So I'll just give you all the risk factors in the form of a mnemonic, that is the smoke. S stands for smoking, right? And you need to remember here that smoking is calculated in the form of the pack years. Now what do you understand by this pack years? It is the packs of cigar per day, right? It is the packs of the cigar per day, that is multiplied by number of years. That is what is called pack years. And M stands for mutation. Mutation of a very important gene, that is SERPINA1 gene, right? That is SERPINA1 gene. And SERPINA1 gene is the one which will code for a protein, that is alpha-1 antitrypsin. that will code for a protein that is alpha-1 antitrypsin. So whenever there is mutation of this SERPINA1 gene, there will be alpha-1 antitrypsin deficiency, and that can predispose to the development of the COPD. And O stands for the occupation. So if you observe the occupation, right, it is the occupation where the individual has exposure to fumes and as well as the chemicals, right, exposure to fumes and chemicals that can cause the development of COPD. And K stands for the combination, right? So even though it starts with word C, just for remembering sake, so combination of bronchial asthma and COPD, that will be a risk for the development of, combination of the bronchial asthma and smoking, that will be a risk for the development of the COPD. See, what actually is the difference between COPD and bronchial asthma is, bronchial asthma and COPD, both of them, they are obstructive lung diseases. But if you take the bronchial asthma, it is a reversible obstructive airway disease. Whereas if you take COPD, it is an irreversible obstructive airway disease. That is the important difference between bronchial asthma and COPD. And E stands for the environmental pollution. Right, E stands for the environmental pollution. Okay, so these are the risk factors for the development of the COPD. Now let me try to discuss COPD in detail. And in case of COPD, what is the important thing that you need to remember here? It is an obstructive lung disease, but it is the disorder where you have irreversible airway dilatation in the emphysema, right? And because of this irreversible airway dilatation, the individual will have the airflow limitation, right? And this irreversible dilatation, it is mainly because of increased inflammatory response within the airways and as well as the lungs. And there are two important subtypes, that is emphysema and as well as the chronic bronchitis, right? These are the two important subtypes. Now you take the emphysema component first. But first of all, let me tell you, both your emphysema and chronic bronchitis, both of them, they are the smaller airway disease. The major site of obstruction in case of COPD will be in the smaller airways. Now what do you understand, or what exactly is the definition of the smaller airways? Smaller airways are those where the internal diameter is less than 2 mm, right? And there is absence of the cartilage. Right, there is absence of the cartilage within this smaller airways. So it is non-cartilaginous airways with an internal diameter of less than 2 mm, right? And the smaller airways are located from approximately 8th generation of the airways down to the terminal bronchiole. Okay, so distal to the 8th generation, right, distal to the 8th generation is what you have the presence of the smaller airways. Now what are the examples of the smaller airway diseases? So the examples of smaller airway diseases, that includes number 1, COPD, next bronchial asthma, next hypersensitivity pneumonitis, next mineral dust pneumoconiosis, and next is the bronchiolitis. Right, next is bronchiolitis. So these are the examples of smaller airway diseases. And risk factors, just now I have discussed, the most common risk factor is what? That is smoking, right? And I have said you all other risk factors, that includes mutation of SERPINA1 gene, occupation like where the individual has exposure to fumes and chemicals, and combination of bronchial asthma and smoking, and environmental pollution, right? Then followed by that, you take this alpha-1 antitrypsin deficiency. So alpha-1 antitrypsin, it has an anti-protease activity. See, alpha-1 antitrypsin deficiency also will contribute to the development of the emphysema, right? Okay, first of all, definition of the emphysema is that emphysema, it is a subtype of the COPD, which is very common in age group more than 55 years. And in patients with emphysema, you have abnormal irreversible dilatation of the airways distal to the terminal bronchiole, right? Distal to the terminal bronchiole. Now, what are the structures which are present distal to the terminal bronchiole? The structures which are present distal to the terminal bronchiole, that includes the respiratory bronchiole, that is number 1, then alveolar duct, that is number 2, then alveolar sac, that is number 3, and then the alveoli. So these are the structures which are present distal to the terminal bronchiole. All these structures, that is respiratory bronchiole, alveolar duct, alveolar sac, and alveoli, they are abnormally irreversibly dilated. That is what you will observe in case of the emphysema. Now, this entire structure, this respiratory bronchiole, alveolar duct, alveolar sac, and alveoli, this entire structure, this is called as the acinus. And this particular acinus, it is mainly required for the air exchange. Now, because the air exchange or gaseous exchange unit is affected, these patients will not have adequate gaseous exchange, and that will result in the development of dyspnea. So the very important clinical manifestation in these patients will be the development of the dyspnea, right? Then coming to the chronic bronchitis. So chronic bronchitis, how is it being defined? The chronic bronchitis is the inflammation of the bronchi, and these patients, they will have the cough with mucoid expectoration, and cough with mucoid expectoration, that will be there for almost 3 months and 2 consecutive years, right? 3 months and 2 consecutive years. That will be like the definition of the chronic bronchitis. And this alpha-1 antitrypsin deficiency will lead to the development of the emphysema. Why? Because the alpha-1 antitrypsin, it has an anti-protease activity. Proteases are the inflammatory enzymes or inflammatory substances which are released from the inflammatory cells, and they cause the destruction of the acinus. And the substance which is protecting from the protease is the anti-protease, which is nothing but alpha-1 antitrypsin, which is coded by the gene SERPINA1 gene. And if that SERPINA1 gene is being mutated, alpha-1 antitrypsin deficiency will occur, and thereby the protease activity cannot be tolerated. You don't have the anti-protease whenever there is alpha-1 antitrypsin deficiency, right? And this alpha-1 antitrypsin deficiency is also observed in case of the bronchiectasis. And alpha-1 antitrypsin deficiency will also cause the development of the cirrhosis of liver. Okay, then you take the subtypes of the emphysema. So subtypes of emphysema, it all depends upon which part of the acinus is abnormally irreversibly dilated. One is panacinar emphysema. Panacinar emphysema is that it is the entire acinus, respiratory bronchioles, alveolar duct, alveolar sac, and alveoli. These are abnormally irreversibly dilated. Okay, that is panacinar emphysema. And this panacinar emphysema, this is very commonly, what is the important etiology for panacinar emphysema? That is alpha-1 antitrypsin deficiency. That will cause the panacinar emphysema, right? And which lobes of the lung are commonly affected in panacinar emphysema? It is the lower lobes of the lung which are commonly affected in case of the panacinar emphysema. Then next we have the centriacinar emphysema. So if you take the centriacinar emphysema, it is only the proximal part of the acinus. It is abnormally irreversibly dilated. Now what do you understand by the proximal part of the acinus? That is only respiratory bronchiole is abnormally irreversibly dilated. And centriacinar emphysema, the important etiology is smoking. And which part of the lung is commonly affected in centriacinar emphysema is the upper lobes of the lungs are commonly affected in centriacinar emphysema. Then next we have the paraseptal emphysema. So paraseptal emphysema is that it is the distal part of the bronchus or distal part of the acinus which is abnormally irreversibly dilated. That includes the alveolar sac and as well as alveoli that are abnormally irreversibly dilated in case of the paraseptal emphysema, right? And next you have, and in paraseptal emphysema, which part of the lung is affected? That is the peripheral part of the lung is abnormally irreversibly dilated in case of the paraseptal emphysema. And in case of the paraseptal emphysema, the peripheral part of the lung which is abnormally irreversibly dilated, you have the emphysematous bulla. And this emphysematous bulla, if it is ruptured, the individual will develop the pneumothorax. So one of the very important complication in patients with emphysema is the development of the pneumothorax. And next is the irregular emphysema. So irregular emphysema mean any part of the acinus can be abnormally irreversibly dilated. That is what is called the irregular emphysema. Then what will be the clinical features in patients with emphysema? The clinical features in patients with emphysema will be the dyspnea. Right, so dyspnea, why? Because the gaseous exchange unit is affected. So these individuals, the gaseous exchange does not occur adequately, and that will result in the development of the dyspnea, right? And on examination, and these patients with emphysema, they will not have the cyanosis, and that is the reason why they are considered as the pink puffers. And what is the, right, pink puffers? What is the age of the patients with emphysema? That is more than 55 years, right? That is where the emphysema is very common. And on examination, they'll have barrel shaped chest. The trachea, it is centrally placed, right? It is not deviated to any of the side. And the chest wall movements will be reduced because the airway is abnormally irreversibly dilated. The recoil does not occur. So the chest wall movements, they are reduced. And the percussion note, you will have the hyper resonant note, right? Hyper resonant note. And the gaseous exchange does not occur. So thereby the breath sounds, they are reduced. Gaseous exchange does not occur, thereby the breath sounds are being reduced. So that is what you will observe in case of the emphysema. Then you take in patients with the chronic bronchitis. In patients with the chronic bronchitis, like the clinical manifestation is what? Cough with mucoid expectoration, right? And it is in moderate quantity. The sputum produced is moderate in quantity. And these patients, they have cyanosis, and that is the reason why patients with chronic bronchitis, they are considered as the blue bloaters, right? They are considered as the blue bloaters, right? And in patients with COPD, you don't have clubbing, right? Clubbing is not the feature of the COPD or chronic bronchitis or the emphysema. And in patients with the chronic bronchitis, on examination, what is that you will have is bilateral basal crepitations. And these crepitations, right, that will be bilateral basal coarse crepitations will be there in patients with the chronic bronchitis, right? Then followed by that, on examination, you will have the bilateral crepitations in patients with chronic bronchitis, and respiratory rate, it is increased, and there will be usage of the accessory muscles of the respiration. There will be usage of accessory muscles of the respiration, like the sternocleidomastoid, the scalene muscles, right, pectoral muscles, they are being used for the respiration because the respiratory rate is increased. And in patients with emphysema, we have discussed that these patients will have dyspnea. And how is that you will be able to assess the severity of the dyspnea is by an important scale, that is the MMRC. Now, what does this MMRC stands for? Modified Medical Research Council Scale, right? Modified Medical Research Council Scale for the dyspnea. That is what is called as the MMRC scaling. Then you take the complications of the COPD. One is the emphysematous bulla. These emphysematous bulla, whenever they rupture, that will result in the development of the pneumothorax, right? And when there is large bulla, they can even interfere with the pulmonary ventilation as well. And these patients will also develop the respiratory failure. Okay, so in case of the emphysema, there will be type 1 respiratory failure in case of emphysema, whereas in chronic bronchitis, you will have the type 2 respiratory failure. In chronic bronchitis, it is type 2 respiratory failure. And apart from that, the other important complications include the development of pulmonary hypertension and as well as the right ventricular failure, which is nothing but the carpal nail. Why? Because there is hypoxia. Hypoxia is the one which will cause the pulmonary artery vasoconstriction, which will result in pulmonary hypertension, which will increase the afterload on the right ventricle, causing right ventricular failure, which is called carpal nail. And these patients will also have secondary polycythemia. Then why is this secondary polycythemia which is being present? That is because hypoxia is the important stimulus for the erythropoietin production, and the erythropoietin which is being produced in increased quantity, that is the one which will cause increase in the production of the RBC, resulting in the secondary polycythemia. Then now you take the workup in patients with the COPD, emphysema, chest x-ray. What will be the important features? I'll show you the chest x-ray also. So these patients, they will have bilateral hyperlucent lung fields, right? Bilateral hyperlucent lung fields, right? Because the airways, they're abnormally irreversibly dilated and they're like completely loaded with air. Then you will be also able to observe the emphysematous bulla. And if you take the shape of the heart, right, it will be a tubular heart, right? So this will be the tubular heart. That is what you will observe, okay? And if you take the diaphragm, it will be a low set diaphragm. Why there will be a low set diaphragm? Because the lungs are abnormally irreversibly dilated, and these abnormally irreversibly dilated lungs will push the diaphragm down, and that will give rise to a low set diaphragm. Then you take the chest x-ray in patients with the chronic bronchitis, you have increased bronchovascular markings, right? There will be increased bronchovascular markings. Then when you do an ABG in patients with the emphysema, I said you these patients will have type 1 respiratory failure, so they will have hypoxia, and carbon dioxide levels, they may remain normal or decreased. That is because of increase in the respiratory rate causing carbon dioxide washout. Whereas in chronic bronchitis, there is inflammation of the bronchi, the carbon dioxide washout does not occur. Thereby these patients will have hypoxia and as well as hypercapnia, and that will result in the respiratory acidosis. That will result in respiratory acidosis. And when you do a pulmonary function test, the pulmonary function test will show you an obstructive pattern, right? Will show you the obstructive pattern. That is what you will notice. And what do you understand by this word obstructive pattern? That is FEV1 by FVC will be less than 70% is what is nothing but the obstructive pattern. Then the treatment completely depends upon the GOLD criteria. What is GOLD criteria? That is Global Initiative for Obstructive Lung Diseases. And in the GOLD criteria, the parameter which is taken into consideration is the FEV1. So based on this FEV1 parameter, like we will be able to decide like what is the treatment in patients with the COPD, which I'll be discussing that in the next question. The GOLD criteria and the respective treatment, I'll be discussing that in the next question. And at the same time, you need to know what are the indications for home oxygen in patients with the COPD. See, there are group 1 and group 2 indications, but let me try to discuss mainly the group 1 indications. Group 1 indications are that when the partial pressure of the oxygen, if it is less than or equal to 55 millimeters of mercury, right? Or if you take the saturation of the individual, if it should be less than 88%. Right, saturation should be less than 88%. So partial pressure of oxygen less than 55 millimeters of mercury, saturation less than 88%, that should be at rest, right? Or at the room air, okay? Then not only that, even during sleep, right? Even during sleep, if the partial pressure of the oxygen, if it is less than or equal to 55 millimeters of mercury, saturation less than 88%, for a patient who is sleeping, that is nocturnal oxygen should be supplemented in these patients. Nocturnal oxygen should be supplemented in these patients. Then next important is you need to know that COPD patients, one of the very important risk factor is smoking. So cessation of smoking is very important. And what is the drug of choice for the smoking cessation is varenicline. So varenicline is considered as the drug of choice, right? And apart from that, we have many nicotine replacement therapies or nicotine buccal sprays or nicotine supplements should be given, right? Nicotine supplements should be given, okay? And this particular nicotine supplements can be in the form of the transdermal patches, can be in the form of gums, can be in the form of lozenges, can be in the form of nicotine inhalers, can be in the form of nicotine nasal spray, right? And apart from that, the other pharmacological therapy include bupropion for the smoking cessation. So this will be the pharmacological therapy in patients with the bronchiectasis. Sorry, pharmacological therapy for smoking cessation. But you take this varenicline, it is effective. But the use of varenicline has been limited by the concerns about neuropsychiatric side effects with the usage of the varenicline. Now let me show you the images of the COPD. Now, this entire structure is acinus, that is respiratory bronchiole, then alveolar duct, alveolar sac, and as well as the alveoli. And accordingly, in paraseptal emphysema, it is the distal part of the acinus which is abnormally irreversibly dilated. Centriacinar emphysema, it is a proximal part of the acinus which is abnormally irreversibly dilated. Then irregular emphysema, any part of the acinus can be dilated. Panacinar, it is the entire acinus which is abnormally irreversibly dilated. Then this is the chest X-ray of the patients with the emphysema. So in case of emphysema, right, in case of the emphysema, you will have the abnormally irreversibly dilated lung, hyperlucent lung fields, right, and you have the presence of the emphysematous bulla, and you have the presence of the tubular heart or the vertical heart, and you have the low-set diaphragm. So this will be the picture in patients with the emphysema. Then this is the chest X-ray picture in patients with the chronic bronchitis. In case of chronic bronchitis, you will notice that there is the increased bronchovascular markings. Normally bronchovascular markings are present only up to 1/3 in the parasternal area. But in patients with chronic bronchitis, the bronchovascular markings, they are like being spread. They are being completely spread. So they can reach even to the beyond 1/3 also parasternal area. Why? Because in patients with chronic bronchitis also they have hypoxia that will cause bronchovascular dilatation. Thereby you will notice that there is increased bronchovascular markings, right? Yeah. So that was about the chest X-ray picture in patients with the COPD, chronic bronchitis, and as well as the emphysema. So the next question in the pulmonology is, a 65-year-old male smoker has been diagnosed with the COPD. On pulmonary function testing, the FEV1 by FVC is less than 0.7 and FEV1 is 42% of the predicted value. The severity of the airflow obstruction in this patient as per the GOLD criteria is mild, moderate, severe, very severe. Now, as I have said you in the previous question, it is the GOLD criteria, that is Global Initiative for Obstructive Lung Disease, is the one which will define the severity of the COPD. And in the GOLD criteria, what is a parameter which is taken into consideration for assessing the severity is the FEV1, right? So, in patients with COPD, the FEV1 by FVC will be less than 70%, right? FEV1 by FVC will be less than 70%. Now, how do you assess the severity of the COPD is, we stage the patients into 1, 2, 3 and as well as 4. You take stage 1, that will be mild COPD. Second will be moderate form of the COPD. Third will be a severe form of the COPD, and then very severe form of the COPD, right? So in all these, what is that we take into consideration? We take the FEV1, that is the volume of air which is exhaled at the end of the first second is what is called FEV1. In case of mild, the FEV1 will be more than 80% of the predicted value. Whereas in stage 2, the FEV1 will be around 50 to 79% of the predicted value. And in stage 3, the FEV1, it is around 30 to 49% of the predicted value, whereas in stage 4 the FEV1 will be less than 30% of the predicted value. Then how is that you will treat these patients with the COPD? In stage 1, that is mild, we give short acting beta agonist. Short acting beta agonist, that is the one which will give the quick relief. And what are the examples of this particular SABA? The examples of this SABA, that includes salbutamol, right? And next is the terbutaline, right, salbutamol and as well as the terbutaline. Now apart from this bronchodilators, we also have the anticholinergic drugs. These anticholinergic drugs include the ipratropium bromide, right, ipratropium bromide and as well as the thiotropium bromide. Okay, so ipratropium and as well as the thiotropium bromide. But between these two, the anticholinergic drugs and as well as the beta 2 agonist, the one which are highly effective in the treatment of COPD is the anticholinergic drugs. And in stage 2, that is the moderate form of the COPD, you need to add long-acting beta 2 agonist, right? You need to add LABA. So what are the examples of these LABA? That includes salmeterol and as well as the formoterol, right? So that will be in moderate. Whereas in case of severe form of COPD, where FEV1 is 30 to 49% of the predicted value, in these patients, you need to add the inhaled corticosteroids, right? So that includes the betamethasone, right, or fluticasone. That should be the inhaled corticosteroids. Whereas in stage 4, which is very severe, where the FEV1 is less than 30% of the predicted value, in these patients, you need to add the oxygen therapy, and at the same time, you also need to consider the surgery, right? At the same time, you also need to consider surgery. So when the FEV1 value, if it is like 42% of the predicted value, then it comes under the severe form of the COPD. Now, pulmonary function test is one of the very important part of the discussion, like where you need to know the differences between the obstructive and as well as the restrictive pattern. Now you take FEV1 and as well as FVC. In all of these conditions, whether you take obstructive or restrictive, it is decreased. But you need to know the severity of the decrease. In case of the obstructive pattern, the FEV1 it is more decreased than compared to that of FVC. That is the reason why your FEV1 by FVC will be decreased and it will be less than 70%. Whereas in restrictive pattern also FEV1 and FVC will be both decreased, but the FVC which is decreased is much more than compared to that of FEV1, and that is the reason why if you take the ratio, either it might be normal in early stages or the FEV1 by FVC will be increased in restrictive lung diseases. Then FEF 25 to 75% means it is a forced mid-expiratory flow rate, right? And this forced mid-expiratory flow rate, it is very much important in obstructive lung diseases, and that will help you in making out the medium and as well as the smaller airway diseases. So the forced mid-expiratory flow rate, it is less than 50% of the predicted value in obstructive lung diseases, whereas restrictive lung diseases also it is being decreased, but it is very important in making out the obstructive pattern of the lung diseases. And TLC stands for the total lung capacity. If you take the total lung capacity, it is increased in patients with obstructive lung diseases, whereas it is decreased in patients with the restrictive pattern. DLCO, it stands for diffusion capacity of the lung for carbon monoxide, and in obstructive pattern, the DLCO is normal in all the forms of the obstructive lung diseases except in patients with the emphysema. In patients with emphysema, the DLCO is increased because in emphysema, the acids, which is the gaseous exchange unit, is affected. So the diffusion of the gases from one alveoli to the other alveoli, or diffusion of the gas from alveoli into the capillary, it gets affected, and thereby the DLCO is reduced in patients with emphysema. Whereas in other causes for obstructive lung diseases, the gaseous exchange does not get affected much, so thereby the DLCO will remain normal. Whereas in restrictive lung disease, it is the entire parenchyma completely replaced by the fibrous tissue. Thereby the DLCO will be decreased in pulmonary causes for restrictive lung diseases. Whereas the DLCO, it remains normal in the extraparenchymal, right? So the DLCO, it remains normal in extraparenchymal, right? It remains normal in extraparenchymal causes for the restrictive lung diseases, right? Whereas intraparenchymal, the DLCO will be reduced. So these are, and one more important is the residual volume. So if you take the residual volume in case of the obstructive lung diseases, residual volume is increased, right? Whereas in restrictive lung diseases, residual volume is decreased mainly in case of the parenchymal causes for restrictive lung diseases, whereas the residual volume, it remains normal in extraparenchymal causes for the restrictive lung diseases. So these are the important differences in between obstructive and restrictive pattern in the pulmonary function test. So this is about the discussion related to COPD. The next important topic for the discussion will be the asthma. Which of the following is not an aim of the asthma therapy? Peak expiratory flow, circadian variation less than 20%, no emergency visits, minimal use of the inhaled corticosteroids, use of the beta-2 agonist, right? Which of the following is not an aim of the asthma therapy? Peak expiratory flow rate, circadian rhythm less than 20%, yes, right? You should ensure that the peak expiratory flow circadian variation should be less than 20%, and that is the aim of the asthma therapy. And there should not be any emergency visits, right? And use of the beta-2 agonist, right? Beta-2 agonist, they are needed for the quick relief of the symptoms. And these are used only on the emergency basis. And they are not given all through the time, right? So once the episodes of the asthma disappear, right, the usage of the beta-2 agonist will also reduce, and they are used only on SOS basis, on emergency basis. So that is also the aim of the asthma therapy. But minimal use of the inhaled corticosteroids, this is not the aim of the asthma therapy. So the aim of the asthma therapy is that there should not be any usage of the corticosteroid therapy at all, right? The corticosteroid usage or requirement should be completely reduced, and completely it should become zero, right? So minimal usage of the inhaled corticosteroid therapy is not an aim of the asthma therapy. Now, let me just discuss the severity of the asthma. We classify the asthma into mild, moderate, severe, and as well as the respiratory arrest. Now, what is that parameter which helps us in making out this particular severity is again the FEV1, right? It is again the FEV1. So based on the FEV1 parameter, or based on the FEV1 by FVC ratio, we will be able to classify the patients into mild, moderate, severe. Let me tell you. Now, in case of mild, how much will be the FEV1? In mild, the FEV1 is more than 70%. Whereas in moderate, the FEV1 is 40 to 69%. Whereas in severe, the FEV1 will be less than 40% or more than 25%. And in very severe, which is nothing but respiratory arrest, where the FEV1 will be less than 25%. Okay, now let me discuss like the symptoms and the examination findings in case of mild, moderate, severe, and as well as the respiratory arrest, which is nothing but the status asthmaticus. So you take breathlessness. So breathlessness in case of mild, it will be there only while walking. Whereas in moderate, the breathlessness will be there even at rest. Okay, and the breathlessness will limit the activity of the individual in case of moderate. Whereas in severe, the breathlessness will be there at rest, and it interferes with the conversation of the individual, right? It interferes with the conversation of the individual. Whereas in respiratory arrest, the breathlessness will be there even at rest, and the individual will be completely mute. He will not be able to talk. Only just monosyllables will be there in respiratory arrest or status asthmaticus, right? And in mild, the individual will be able to talk in sentences because the breathlessness is there only on walking. So at rest, he'll be able to talk in sentences. Whereas in moderate, right, they can talk in phrases. Whereas in severe, words. And in respiratory arrest, they are completely silent and they are not able to talk. And what about the alertness? In case of mild, the individual will remain agitated. Whereas in case of the moderate, usually they are agitated. Whereas in case of mild, intermittently, okay, or agitation may be there occasionally. Whereas moderate form of asthma, the agitation will be there throughout the day. That is because of the hypoxia and hypercapnia. And in severe form, they are usually agitated. Whereas in respiratory arrest, the individual will be in a state of drowsiness and confusion, right? Drowsiness and confusion. That is about the alertness. And you take the respiratory rate. In case of mild, the respiratory rate is increased. Moderate also respiratory rate is increased. And in severe also, the respiratory rate will be more than 30 per minute, and even in respiratory arrest also, the respiratory rate will be more than 30 per minute, where there will be severe form of tachypnea. And if you take the body position in case of mild, these patients, they can lie down in supine position, whereas in moderate, these patients, they prefer sitting, whereas in severe, they completely sit upright. Whereas in respiratory arrest, the individual is unable to recline. Right? Unable to recline. That is what in case of the respiratory arrest. And what about the usage of the accessory muscles of the respiration or suprasternal retractions? In case of mild, the usage of the accessory muscles, usually it is not there. And in moderate, commonly there is usage of the accessory muscles. In severe, usually there is usage of the respiratory muscles, whereas in respiratory arrest, these individuals, they will have the paradoxical movements. So paradoxical movement is that where usually upon upon respiration, like what is that should happen? The chest wall, it expands during inspiration and it deflates during expiration. And paradoxical, in the sense, paradoxical thoraco-abdominal movement, right? See, in females, it is thoraco-abdominal type of respiration, whereas in males, it is abdominothoracic type of respiration. Paradoxical movement is that it is completely, either you take in males or females, it is completely thoraco-abdominal movement will be there. And what about wheeze? Wheeze, right? It is present, moderate wheeze, and the wheeze is present mainly during the expiration in case of mild, whereas in moderate, the wheeze, it will be loud and it is present throughout the expiration, whereas in severe also, the wheeze, it is usually loud and it is present both during inhalation and as well as the exhalation, whereas respiratory arrest, right, wheeze is completely absent. Why? Because the airway becomes so narrow that passage of the air does not occur in case of the respiratory arrest. Whereas you take in case of mild, what will be the pulse rate? It will be less than 100 per minute, whereas in case of moderate, it is usually 100 to 120 per minute, whereas in severe, the pulse rate will be more than 120 per minute, whereas in respiratory rate arrest, in these patients, they'll have severe form of tachypnea or even they go into a state of the bradycardia. Pulsus paradoxus, it is present in case of the respiratory arrest, where upon inspiration, the systolic blood pressure will fall by more than 10 millimeters of mercury. That is what is your pulsus paradoxus. And if you take the functional assessment of these individuals, just now as I was discussing, the FEV1 will be more than 70% of the predicted value in mild, 40 to 69% in case of the moderate, and in severe it is 25 to 40%, whereas in the respiratory arrest, the FEV1 will be less than 25% of the predicted value. And if you take the partial pressure of the oxygen, in case of mild, the partial pressure of the oxygen will be more or less normal, whereas in moderate, it will be more than 60%, right? And PaO2 in severe, it will be less than 60%, and usually these patients will develop the cyanosis. Whereas in respiratory arrest, right, here also it will be less than 60% of the value in the room air. And partial pressure of the carbon dioxide, there will be severe form of hypercapnia in severe, and as well as in respiratory arrest, there will be hypercapnia, and that will result in the respiratory acidosis or type 2 respiratory failure, right, or type 2 respiratory failure. Now, in the treatment, if you take the treatment, it completely depends upon the severity of the bronchial asthma. So you take mild. Now, if the individual is having mild intermittent form of the bronchial asthma. In mild intermittent form of bronchial asthma, you need to give short-acting beta agonist, and this short-acting beta agonist, that should be given only on the emergency basis. Whereas, if the individual is having mild persistent form of the asthma, in mild persistent form of the asthma, these patients, they have to be added inhaled low dose corticosteroids. Right? Inhaled low dose steroids. That is in case of mild. Whereas in case of moderate persistent form of asthma, these patients, they will be requiring, along with the short acting beta agonist, so here also they will be requiring short acting beta agonist. So along with the requirement of the short acting beta agonist, they will be requiring inhaled high dose corticosteroids. Right? That is in case of moderate. Whereas in severe, that is in severe persistent form, these patients, they will be requiring the oral steroids. Right? And they will be also requiring the short acting beta agonist, and they will be also requiring like phosphodiesterase inhibitors, that is the theophylline should be given. Theophylline should be given. Okay. Whereas in respiratory arrest, these patients, they will be requiring the intravenous steroids. Right? Intravenous hydrocortisone is required in case of the respiratory arrest, and the entire treatment, it is completely a stepwise approach. Right? So step 1, they will be requiring the SABA, short acting beta agonist, on the SOS basis, and step 2, they will be requiring low dose inhaled corticosteroids. Step 3, you need to add LABA. Step 4, you increase the dosage of the inhaled corticosteroids, and in step 5, you need to make high dose inhaled corticosteroids. LABA and omalizumab should be given. And in step 6, along with the high dose inhaled corticosteroids, LABA and oral corticosteroids should be added, and omalizumab for patients who have the allergies. So this will be like stepwise approach in case of the asthma therapy. Then what exactly is the drug of choice for acute asthma exacerbation? For acute asthma exacerbation, it is the salbutamol nebulization. That will be the drug of choice. And for recurrent attacks, like what exactly is the drug of choice? For recurrent attacks, you need to add the inhaled steroids. Right? You need to add the inhaled steroids, and these inhaled steroids include the fluticasone and as well as the budesonide. And along with that, long-acting beta agonist should be added. And for chronic persistent asthma, the drug that you need to give is the omalizumab. That should be given in case of chronic persistent asthma. Whereas in brittle asthma, the drug which is very important is subcutaneous adrenaline should be added. Right? Subcutaneous adrenaline should be added. And the drugs which are given for prophylaxis are mainly leukotriene modifiers and mast cell stabilizers. These two drugs, they are not given for acute attacks. And examples of the leukotriene modifiers, that includes Xileuton, right? And another important molecule is montelukast. So montelukast and as well as the zeferlukast or Xileuton. So these are the examples of the leukotriene modifiers. And mast cell stabilizers, examples include nidochromyl sodium, right? Nidochromyl sodium, and the other important molecule is sodium chromoglycate. Right? Sodium chromoglycate, and next one is ketotifen. Okay, so these are the examples of the mast cell stabilizers. Now, and after having discussed about the drugs and their respective choices, you need to know what are the indices which will determine the control of the bronchial asthma. The indices which will be determining the control of asthma, number 1, the daytime symptoms of the bronchial asthma, it should be less than twice per week. Right? It should be less than twice per week. And next, short acting beta 2 agonist, that is SABA inhaler, should be used. The requirement of the SABA, it should be less than twice per week. And number 3, there should not be any nighttime symptoms. So no nighttime clinical features. And third, there should not be limitation of the activity. Right? No limitation of the activity. Right? And fifth, the peak expiratory flow rate, it should get normalized. So normal peak expiratory flow rate and FEV1 values. right? Normal peak expiratory flow rate and FEV1 values. So these are the indices which will determine the control of the bronchial asthma, right? So this is about the treatment aspect and as well as the assessment of the severity of the bronchial asthma. One more question on asthma. A 40-year-old patient of bronchial asthma presents with acute severe breathlessness. Indications for giving him the assisted ventilation for acute severe asthma include which of the following? Partial pressure of the oxygen less than 80 and carbon dioxide less than 45. Partial pressure of oxygen more than 60, carbon dioxide more than 45. Partial pressure of the oxygen less than 60, carbon dioxide more than 45, and partial pressure of the oxygen less than 80, carbon dioxide more than 45 millimeters of mercury. So you need to know what are the indications for the assisted ventilation in patients with the bronchial asthma. That is hypoxemia, where partial pressure of oxygen is less than 60, and hypercapnia, where the carbon dioxide value is more than 45. That is the indication for giving the assisted ventilation in patients with the bronchial asthma. Now, let me tell you all other indications. So number one, there should be severe hypoxemia. And how much should be there? The severe hypoxemia where the partial pressure of oxygen, it should be less than 60 millimeters of mercury despite high flow oxygen. Right? Despite high flow oxygen therapy. And next is the hypercapnia. Hypercapnia is that where the partial pressure of the carbon dioxide, it should be more than 45 millimeters of mercury. That indicates the ventilatory failure. That indicates a type 2 respiratory failure. They will be requiring assisted ventilation. And you take respiratory acidosis, right? Where the pH of the individual, it is less than 7.35, right? And that is due to increased partial pressure of the carbon dioxide. So that is an indication for assisted ventilation. Next is the severe respiratory distress, right? Where there is clinical signs of marked use of the accessory muscles of respiration. Right? Accessory muscles of respiration. And the patient is like completely fatigued. Right? And the patient is also having paradoxical abdominal movement. Right? Paradoxical abdominal movement. And next is the altered mental status. So because of the hypoxia or because of the hypercapnia, right? If the individual is in a state of confusion or if the individual is in a state of drowsiness, right, that is an indication for assisted ventilation. Then cardiovascular instability, right, such as the patient is having hypotension, such as the patient is having severe form of bradycardia, or such as the patient is having the arrhythmias in a case of the bronchial asthma. That's an indication for the assisted ventilation. And then impending respiratory arrest. So the clinical signs of impending respiratory failure despite aggressive medical therapy. So these are the criteria, or these are the indications for the assisted ventilation in patients with the bronchial asthma, right? Next question. Which of the following are controller therapies in the management of the acute asthma? The anticholinergic, systemic glucocorticoids, inhaled glucocorticoids, omalizumab. So anticholinergics, yes, these are the controller therapy. Then inhaled glucocorticoids, these are also the controller therapy. Omalizumab, it is also the controller therapy. But systemic glucocorticoids, they are given for acute attack. They are not the one which are given for the controller therapy. If you take the entire management of bronchial asthma, we have the two categories of drugs in the treatment of the bronchial asthma. What are these two categories of drugs? Number one, they are considered as the bronchodilators. And the very important pathogenesis in the bronchial asthma is inflammation. So anti-inflammatory drugs. Right? So anti-inflammatory therapy or anti-inflammatory drugs. Now if you take the bronchodilators examples, like we have short-acting beta agonist, example salbutamol, and the other one is terbutaline. And next we have the LABA, long-acting beta-2 agonist. Example, salmeterol and formoterol. Then we have anticholinergic drugs that includes ipratropium bromide and as well as thiotropium bromide. Then we have the phosphodiesterase inhibitors. And examples of the phosphodiesterase inhibitors include theophylline, right? That includes theophylline, that is a phosphodiesterase. So these are all your bronchodilators. Then we have the anti-inflammatory drugs. The anti-inflammatory drugs include the inhaled corticosteroids or the systemic corticosteroids. Right? Inhaled corticosteroids and as well as the systemic corticosteroids. Then we have the leukotriene inhibitors. Examples of the leukotriene inhibitors include montelukast and the other one is zeferlukast or Xileuton. Then we have the mast cell stabilizers. Mast cell stabilizers, they include cromolyn sodium, then nidochromyl sodium, right? Chromyl sodium and nidochromyl sodium. These two are the examples of the mast cell stabilizers. Then we have another important example, that is anti-IgE. The example of anti-IgE is omalizumab. And if you take this omalizumab, this is the drug which is given in individuals who are having chronic refractoriness to the other forms of the therapy. So this is, and out of these, the systemic glucocorticoids, they are given for the acute attack. They are not given as the controller therapy. Whereas your SABA or your anticholinergic drugs and phosphodiesterase inhibitors and omalizumab, they are given as controller therapy for acute attacks, but not for the acute attack. Acute attack, we give systemic steroids, right? So that was about the treatment aspect. Then, yes, diagnostic workup for a case of suspected bronchial asthma should reveal which of the following abnormalities: reduced FEV1 by FVC, increased functional residual volume, reduced diffusion capacity, increment in FEV1 in response to inhaled bronchodilators. So, diagnostic workup for a case of suspected bronchial asthma should reveal that there should be reduced FEV1 by FVC and there should be increased functional residual volume and as well as residual volume also. And you take the diffusion capacity. Diffusion capacity is not affected in patients with the bronchial asthma, and there should be increment in the FEV1 in response to bronchodilators. So the correct answer is 1, 2 and as well as 4. Now let me discuss in detail about the entire bronchial asthma. So until now, like what we have discussed is only the treatment aspect and as well as the CVRT assessment. Now let me just discuss in detail about the bronchial asthma. So if you take the bronchial asthma like COPD, this is also a disease of the smaller airways, right? But what is the important difference between the COPD and the bronchial asthma? It is a disorder where you have a reversible bronchial obstruction, right? It is a disorder where you have reversible bronchial obstruction, okay? And this bronchial obstruction, it is mainly due to hyperresponsiveness of the tracheobronchial tree, right? It is due to hyperresponsiveness of the tracheobronchial tree. And this hyperresponsiveness of the tracheobronchial tree, it is due to multiple intrinsic and as well as the extrinsic stimuli. And these patients, the important clinical manifestations will be dyspnea and as well as wheeze. Dyspnea and as well as wheeze. That will be the manifestation. And apart from that, these patients will also have cough with expectoration. And the asthma, we have two forms, extrinsic and as well as the intrinsic asthma. The extrinsic asthma is why is it called extrinsic? Because the external allergen has a role in the development of asthma. And it is also called atopic asthma because it is the allergy manifestation or hypersensitivity reaction is there in case of the extrinsic asthma, right? Or it is also called as the early onset asthma because it is a disorder which is usually observed in children. That is the reason why it is called the early onset asthma. And in these individuals, the IgE levels are elevated, the eosinophil levels are increased, and in these patients, the provocative test or skin sensitivity test, that will be positive. The skin hypersensitivity test will be positive. Whereas you take in case of the intrinsic asthma. Intrinsic asthma, it is also called intrinsic asthma, means there is no role of the external allergen. It is only the infections within the lung that can predispose the individual for the development of asthma. And it is also called non-atopic. Why? Because there is no role of atopy or allergy. And it is also called late onset asthma. Why? Because it is the disorder which occur in elderly individuals or adults. That is the reason why it is called as the late onset asthma. And in these individuals with intrinsic asthma, the IgE levels that will remain normal, whereas the eosinophils, they also remain normal, and the skin sensitivity test will be negative. And what is the type of hypersensitivity reaction that you will have in extrinsic asthma is, it is a type 1 hypersensitivity reaction. Right, it is type 1 hypersensitivity reaction. And for the development of asthma in the pathogenesis, if you observe, what are the cells which are involved in the release of the inflammatory mediators? The important cells which are involved are like the mast cells, then important are the macrophages, then followed by that the very important cells will be eosinophils, then lymphocytes. So these four cells, mast cells, macrophages, eosinophils and lymphocytes, they are the important cells which are involved in the release of the mediators, and the less important cells will be the neutrophils, then followed by that platelets, then followed by that the platelets. Then what are the inflammatory mediators? So if you take the inflammatory mediators which are released from these inflammatory cells, they include histamine that will cause the bronchoconstriction. Right, and apart from the histamine, the other inflammatory mediators are the prostaglandins, then thromboxanes, then leukotrienes. Examples of the leukotrienes are LTB4, C4, D4 and E4. Then the platelet activating factor, then bradykinin, then the TNF alpha, that is tumor necrosis factor alpha. And we have another important substances like adenosine and as well as the substance P. Then what are the, so these are the inflammatory mediators which are released that will cause bronchoconstriction. Then what are the factors that will precipitate the asthma? The factors that will precipitate the asthma, that includes the allergens. That includes the allergens such as food, pollen, mold and dust mites. These are the allergens. Then next important is smoking. Right, so smoking of like smoking and exposure to perfumes or the sprays. Then temperature variation, exposure to the extreme cold. Next, hay fever. Right, next is the hay fever and infections, both bacterial and as well as the viral infections. Then the clinical features, as I have said you, the very important is dyspnea, and they'll have cough with sputum production. And the sputum which is being produced in patients with bronchial asthma, they have some peculiar substances called 𝗂𝐻𝐿 spirals. Right, and these 𝗂𝐻𝐿 spirals, these are spiral shaped mucus plugs. These are 𝗂𝐻𝐿 spirals. Then Crayola bodies. What are these Crayola bodies? These Crayola bodies, they are ciliated columnar cells. These ciliated columnar cells are the ones which are sloughed from the bronchial mucosa. These are Crayola bodies. Then next is the presence of the charcote-laden crystals. Right, charcote-laden crystals. These charcote-laden crystals, they are slender and pointed at both the ends. That is what is your charcote-laden crystals. And these charcote-laden crystals which are slender and pointed at both ends, they are indicative of the eosinophilic inflammation, right? And now these charcote-laden crystals are not just present only in case of bronchial asthma. They are also present in allergic reactions, and they are also present in the parasitic infections. Okay. Then on examination, these patients, they will have wheeze. So usually the wheeze is present only during expiration, but when the individual is having severe form of bronchial asthma, the wheeze is present both during expiration as well as the inspiration. Then what are the other causes of the wheeze? And on examination, the other important feature is respiratory rate is increased, heart rate is increased, then accessory muscles of respiration, they are being used, right? And what are the other causes of wheeze? That includes the cardiac asthma, which is nothing but the pulmonary edema, which is nothing but cardiogenic pulmonary edema, which is called cardiac asthma. Then COPD, then recurrent pulmonary emboli, right? Then carcinoid tumors, right? The carcinoid tumors. Okay, so these are the and next important is the endobronchial lesions or endobronchial foreign body. Even these can cause the development of the wheeze. Then you need to know the variants of the asthma. We have what is called nocturnal asthma. Nocturnal asthma, it is defined as an overnight fall in the FEV1. And how much should be that fall in FEV1? More than 20%. Right? Gastric asthma is that immediately after taking food, these patients will have the asthma. And that is due to GERD, gastroesophageal reflux disease, and the treatment that you need to give is the proton pump inhibitors. These patients, they don't respond to the bronchodilators, right? Then exercise-induced asthma. Exercise-induced asthma or exercise-induced bronchoconstriction, they begin during the exercise, right? Or within 3 minutes of starting the exercise, there will be development of the asthma. So by almost 10 to 15 minutes, the severity of the asthma, it will reach the peak value, and by 60 minutes the asthma, it will get completely resolved. So how can you prevent this exercise induced asthma is before the onset of asthma you need to give, before starting of the exercise, you need to give bronchodilators. That is what is your exercise induced asthma. Next is drug induced asthma. Drug induced asthma, very commonly observed in case of the supplementation of COX-1 inhibitors, and as well as very examples are diclofenac and as well as the ketorolac. What these drugs basically do is they will inhibit this COX enzyme and they will increase the levels of the leukotrienes, which will cause the bronchoconstriction. Okay, and even aspirin is also the drug which can cause drug-induced asthma. So aspirin, diclofenac, and as well as the ketorolac. Cardiac asthma, like secondary to pulmonary edema, and that can be seen in left ventricular failure or left-sided valvular pathologies, MR, MS, AR, and AS. Next is the status asthmaticus, which is a severe form of asthma, and in these individuals, the individual will be completely hypoxic, there will be hypercapnia, and there will be cyanosis, and the respiratory rate will be more than 30 per minute, and heart rate will be more than 100 per minute, and these individuals, they cannot speak the complete sentences or even phrases, so they will have only just monosyllables. They will just have only monosyllables. That is what, and these patients, they have a characteristic pulse, that is pulsus paradoxus. That will be the feature in case of status asthmaticus. And in these patients, you should know what is the treatment. The drug of choice is intravenous hydrocortisone should be given, right? And you also need to supplement the short-acting beta-2 agonist, and the terbutaline phosphodiesterase inhibitors also should be given, right? But along with this, oxygen therapy is very important. Then the other variant of asthma is the brittle asthma. Brittle asthma is that some patients, they show chaotic variation or abrupt variation in the lung function despite taking appropriate therapy, where if you take the diurnal variation of the peak expiratory flow rate, the diurnal variation of peak expiratory flow rate will be more than 40% in patients with the brittle asthma, right? What is the difference between type 1 and type 2? Type 1 is that there is persistent pattern of the variability, and the treatment in case of type 1 where there is persistent pattern of the variability, these patients may require oral corticosteroids, right? These patients will require the oral corticosteroids, or you need to give continuous infusion of the beta-2 agonist. Continuous infusion of the beta-2 agonist. Whereas you take type 2 brittle asthma. Type 2 brittle asthma is that these individuals, they have generally normal or near normal lung function, and there is unpredictable fall in the lung function, and these patients, they can even have death. And how is that you will treat type 2 brittle asthma? So type 2 brittle asthma, right, you need to give subcutaneous epinephrine. Right, subcutaneous epinephrine is what we give in case of the type 2 brittle asthma. Then what is the investigations that you need to do. One is your pulmonary function test, which will show you an obstructive pattern. But what is the investigation of choice is the reversibility testing, right? Reversibility testing. What is the reversibility testing? You need to check the baseline FEV1, and then you need to give salbutamol nebulization, and you need to wait for 10 to 15 minutes, and then again you need to check the FEV1. And once again, if you check the FEV1, you will find that there will be increase in FEV1 by more than 12%. That is what is considered to be bronchial asthma. Whereas the increase in FEV1 is less than 12%, then that patients are considered to be the COPD. So increase in FEV1 should be more than 12%, right? Or like increase in FEV1, it should be 200 ml, right? It should be increase in 200 ml. And when you do an ABG, right, in case of mild to moderate form of asthma, there will be like type 1 respiratory failure, where they will have the hypoxia and as well as the hypocapnia. Whereas in case of severe or very severe form of bronchial asthma, they will have type 2 respiratory failure, where there will be hypercapnia causing respiratory acidosis. And the provocative test, and these provocative tests include the methacholine provocation test or the histamine challenge test, right? So whenever you give methacholine or histamine, there should be or there will be fall in the FEV1. And how much will be the fall in FEV1? That is by more than 20% after provocating with these agents. And if the provocative tests are positive, that is indicative of the presence of the airway hyperresponsiveness. That is the importance of your provocative test or histamine or the methacholine challenge test. And the chest X-ray in patients with bronchial asthma, during the acute attacks, right? During the acute attacks, the X-ray, it appears completely hyperinflated, right? Whereas between the attacks, if you observe, right, between the attacks, the X-ray will be absolutely normal. Right, so this is about the variants of asthma and complete detailed discussion of the bronchial asthma. And in my previous questions, like I have discussed about the treatment of the bronchial asthma. So this completes the discussion of bronchial asthma. Quick revision. So the next topic for the discussion in the pulmonology is about the bronchogenic carcinoma. So the question is, which of the following are the non-metastatic extrapulmonary manifestations of the lung cancer? Carcinoid syndrome, nephrotic syndrome, Horner's, Lambert-Eaton myasthenic syndrome. So the correct answers are the carcinoid syndrome. It is one of the non-metastatic extrapulmonary manifestation of the lung cancer, and Horner's and as well as the Lambert-Eaton myasthenic syndrome. So the correct answer is 1, 3 and as well as the 4, right? And the non-metastatic extrapulmonary manifestations of lung cancer, they include various paraneoplastic syndromes, right? And you take the first one, that is carcinoid syndrome. So if you see the evaluation of the individual options, carcinoid syndrome, this syndrome is typically associated with the carcinoid tumors, which can originate in the lung, but they are non-specific to the lung cancer. And the characteristic features of the carcinoid syndrome, that includes like there will be release of the metabolites or the products of the serotonin. The clinical manifestations, they include flushing, there can be development of the diarrhea, and there will be also development of the wheezing. So flushing, diarrhea and as well as the wheezing. So these are due to the release of the serotonin and other substances, right? And it can be an extrapulmonary manifestation, but it is more specific to the carcinoid tumor rather than the general lung cancer. Which one? These manifestations. And you take nephrotic syndrome. This is a renal disorder. What will be the characteristic manifestation in these patients will be the proteinuria. And what will be the quantity of the proteinuria? The quantity of the proteinuria will be more than 3.5 grams per 24 hours, and in which mainly the albumin is excreted out, resulting in hypoalbuminemia. And because of the hypoalbuminemia, these patients will also develop the edema. And the other features of the nephrotic syndrome will be hyperlipidemia, lipiduria and hypercoagulability, right? And this nephrotic syndrome, it is not among the most common paraneoplastic syndromes associated with the lung cancer. So your nephrotic syndrome is not a paraneoplastic syndrome. Then you take the Horner syndrome. The Horner syndrome, what will be the manifestation of the Horners? That includes ptosis, then meiosis, where there will be constriction of the pupil, then enophthalmos, where there will be inward enophthalmosis, right, where there will be inward movement of the eyeball, then anhidrosis, right, where there is absence of the sweat secretion, then loss of the ciliospinal reflex, right, loss of the ciliospinal reflex. Okay, so these are the manifestations of the Horner syndrome. And in which clinical condition you have this Horner syndrome, or in which particular tumor you have this Horner syndrome is, this Horner syndrome, it is the consequence of the Pancoast tumor, right? And which particular tumor can cause the Pancoast? It is the adenocarcinoma of the lung, which are growing at the periphery or even at the apex. Next is Lambert-Eaton myasthenic syndrome. Lambert-Eaton myasthenic syndrome, it is a neuromuscular junction disorder, and that too, it is a presynaptic neuromuscular junction disorder, and it is associated with the oat cell carcinoma of the lung, which is nothing but the small cell carcinoma of the lung, right? So this is one of the paraneoplastic syndrome, okay, related to the lung cancer. So the answer is 1, 3 and as well as 4. Now if you see some of the very important questions in the bronchogenic carcinoma, right, the most common benign tumor of the lung, that includes the hamartoma. So hamartomas, these are the most common benign tumors. And what is the most common cause of recurrent hemoptysis is bronchial adenomas. They are the most common causes for recurrent hemoptysis. And most common cause of the cancer death, that will be among all the cancers, it is the lung cancer, right? It is the lung cancer that is the most common cause of the cancer death. And what is the most common risk factor for the development of the bronchogenic carcinoma? The most common risk factor will be smoking. And the most common natural risk factor or environmental risk factor will be exposure to the radon gas. And exposure to the radon gas, this is very common in the uranium miners. And the most common rib that is destroyed in the Pancoast tumor will be the first rib, right? This will be the first rib. And the most common nerve roots which are involved in the Pancoast tumor, that will be C8, T1 and as well as T2. And what is that particular tumor which will be causing Pancoast? That is the adenocarcinoma of the lung. And the most frequent, the histological type of the bronchogenic carcinoma, that includes the adenocarcinoma, whereas the most frequent histological type, this is the most frequent histological type globally, but whereas the most frequent histological type in India, this will be squamous cell carcinoma of the lung. And most common histological variety in non-smokers, that will be adenocarcinoma, whereas in young patients and in females also, the most common histological type will be the adenocarcinoma. And the most common site for metastasis from carcinoma of the lung, that will be mainly to the liver. That is mainly to the liver. And most common endocrine organ to be involved by metastasis of the carcinoma lung, that will be the adrenal gland, right? So that will be the adrenal gland, right? Then the next important set of questions are the carcinoma lung which will metastasize to the opposite lung, that will be adenocarcinoma. The most common tumor to metastasize to the heart, that will be the carcinoma of the lung. And the histological varieties that will cavitate, that includes the squamous cell carcinoma of the lung and as well as the large cell carcinoma of the lung, right? And the histological varieties that are central in distribution, that will be the small cell carcinoma of the lung, and next is the squamous cell carcinoma of the lung. And the histological varieties that are peripherally distributed, that includes adenocarcinoma of the lung. And most common variety associated with paraneoplastic syndromes, that will be small cell carcinoma of the lung. That will be small cell carcinoma of the lung, which is associated with the many of the paraneoplastic syndromes, right? And the type of bronchogenic carcinoma associated with hypokalemia, that will be small cell carcinoma of the lung. I'll explain you why in subsequently. And most common variety associated with hypercalcemia, that will be squamous cell carcinoma of the lung. And histological variety most responsive to chemotherapy and radiotherapy, that will be the Oat cell carcinoma, which is nothing but the small cell carcinoma. But the histological variety with best prognosis will be squamous cell carcinoma of the lung. Right, so these are some of the important single liners related to the bronchogenic carcinoma. Now let me discuss in detail about the bronchogenic carcinoma. So bronchogenic carcinoma as such, it is a malignant neoplasm, right? And the types, as just now we have discussed, that includes the adenocarcinoma, then squamous cell carcinoma, then small cell carcinoma, then large cell carcinoma. Okay, then the most common etiology globally, that will be adenocarcinoma, whereas in India it is the squamous cell carcinoma. And what is the most common environmental risk factor? That will be exposure to the radon gas. And not only exposure to the radon gas, apart from smoking and apart from exposure to the radon gas, the other etiologies that will be contributing to the development of bronchogenic carcinoma is exposure to the asbestos, right? Exposure to the asbestos. And these patients who are having exposure to the asbestos and upon that they are also smokers, there is almost 60 to 100 times increased risk of development of bronchogenic carcinoma. Then next is the metals. Metals like the arsenic, metals like the chromium, metals like nickel, metals like the iron oxide can also cause the development of bronchogenic carcinoma. And we have an industrial carcinogen, and this industrial carcinogen is bischloromethyl ether, right? Bischloromethyl ether. So these are the various etiologies that will be causing bronchogenic carcinoma. Now if you take some of the important points about the individual forms, you take adenocarcinoma. This is the most common bronchogenic carcinoma globally, and this is more common in females rather than males. And which part of the lung is commonly affected is the peripheral part of the lung is affected in adenocarcinoma, right? And by the time the individual presents to the doctor with the clinical manifestations, these patients, they will be in the advanced stages of the disease, because when the tumor is present peripherally, the individual is asymptomatic in early stages. But when the tumor spreads from the peripheral part of the lung to the central part of the lung, that is the point when the clinical manifestations will develop and he will be in the later stages of the disease. And this particular adenocarcinoma, this is associated with the development of scarring, and most of the time these adenocarcinoma, they are found or they are diagnosed incidentally on the routine chest radiograph. And these adenocarcinomas, they grow more slowly than compared to that of the squamous cell carcinoma, right? So that is about the adenocarcinoma, right? And you take the small cell carcinoma. Small cell carcinoma, the another name for this is, it is also called as the Oat cell carcinoma, right? It is also called the Oat cell carcinoma. So this Oat cell carcinoma, it is the most aggressive variant, right? And it is the disorder where the individual will have worst prognosis, and smoking is the risk factor for the development of small cell carcinoma, and it is centrally located tumor, right? And this small cell carcinoma, it undergoes micrometastasis to the distant organs. And you take the squamous cell carcinoma. Squamous cell carcinoma, it is also the tumor which has central distribution, right? And there is also cavitation within the lung parenchyma, and the important clinical manifestations will be hemoptysis, and there will be also development of the hilar lymphadenopathy, right? And it has the invasion, there will be local invasion, and it is a slowly progressive tumor, right? It is a slowly progressive tumor. Which one? The squamous cell carcinoma of the lung. Whereas large cell carcinoma, it has both the peripheral distribution and as well as the central distribution. And it is also the disorder where the individual has a completely poor prognosis. And the most common symptom that these individuals will have is cough with copious amount of the expectoration. And this expectoration that these individuals will have is the serous inconsistency. And why is this particular cough? That is secondary to irritation or compression of the bronchus by the tumor. And these patients will also develop dyspnea. And why is that they have dyspnea? That is due to the central airway obstruction. That is due to compression causing the atelectasis. And these patients will also have wheezing. Now, what is the reason why these patients have wheezing? Is that is due to narrowing of the central airway more than 50%. And these patients will also have the hemoptysis, right? The hemoptysis, that is mainly because of the metastasis or the spread of this particular tumor into the bronchial vasculature, causing rupture of the bronchial vasculature. And these patients will also develop the pneumonia. So now, why is that they have pneumonia? That is usually due to airway obstruction by the tumor, and the foreign organisms which are entering into the airways, they are not being expelled out. And this pneumonia, it can also progress to the development of the lung abscesses as well. So these will be the pulmonary manifestations. And you have two important syndromes, that is SVC syndrome and as well as the Pancoast syndrome. Now, what do you understand by this SVC syndrome? That is superior vena cava syndrome. That is usually observed in case of like small cell carcinoma of the lung, where this small cell carcinoma will compress the superior vena cava. Once this small cell carcinoma compresses the superior vena cava, the venous drainage from the face and as well as the upper limbs into the right side of the heart does not occur. That is what is here the SVC syndrome, which is commonly observed in small cell carcinoma. These patients, they'll have facial flushing. There will be swelling of the neck veins. There will be also swelling of the upper limbs, right? And in SVC syndrome, these patients will also have headache and conjunctival congestion. Then you take the Pancoast syndrome. So you take the Pancoast syndrome, like it is commonly observed in the adenocarcinoma. And the features of the Pancoast is that, so it is the tumor which is basically growing at the apex, right? It is a tumor which is basically growing at the apex of the lung. And this particular tumor, it will compress the cervical spinal nerves, that is C8, and thoracic spinal nerves T1 and T2. Thereby these individuals will have pain within the neck, and that will be radiating even to the arm. And these patients will also develop the Hornets. And regarding the Hornets, just now I have discussed that in detail, right? Then coming to the ectopic hormones, some of the types of bronchogenic carcinomas, like for example small cell carcinoma, it will produce ACTH, and thereby these patients can develop the Cushing's syndrome, right? And for the development of the Cushing's, it is not just only the adrenal pathology or pituitary pathology. Ectopic ACTH can be seen from the small cell carcinoma or oat cell carcinoma causing the Cushing's syndrome. Then this particular small cell carcinoma will also produce excess amount of antidiuretic hormone, resulting in the SAADH. And not only that, these small cell carcinoma will also produce excess amount of the atrial natriuretic factor, and this will induce the development of the hyponatremia. So in SAADH and the condition where there is increased atrial natriuretic factor, that will result in the development of the hyponatremia, right? And the next important is the small cell carcinoma will also produce the calcitonin, right? And because of the production of the calcitonin, these patients will develop hypocalcemia. And because of the production of gonadotrophins, these patients, so small cell carcinoma will also produce excess amount of gonadotrophins, and because of the excess production of the gonadotrophins, there will be also development of the gynecomastia, right? And squamous cell carcinoma, if you observe squamous cell carcinoma, this will produce parathormone related protein, and this parathormone related protein is the one which will cause the hypercalcemia. So these are the ectopic hormones or the paraneoplastic syndromes associated with the bronchogenic carcinoma. And chest x-ray, if you observe, you have the presence of the mass within the lung parenchyma, and this mass, right, this will cause widening of the mediastinum. And HRCT, it is useful for the evaluation of the size of the tumor, right? It is useful to evaluate the size of the tumor, and it is also useful to assess the spread of the tumor. It is also useful to make out if there is any destruction by the tumor. The investigation of choice is bronchoscopy plus biopsy. Right, so bronchoscopy plus biopsy, that is the investigation of the choice. Then what are the tumor markers? The tumor markers are, number one, the carcinoembryonic antigen. This carcinoembryonic antigen, it is the marker of the metastatic cancer. It is a marker of metastatic cancer. And the other one is NSE. NSE stands for neuron specific enolase. Neuron specific enolase, this is a prognostic marker. Right, so this is the prognostic marker in case of the small cell carcinoma of the lung. Right, so that is about the neuron specific enolase and carcinoembryonic antigen. Carcinoembryonic antigen, it is the metastatic, it is a marker for metastasis. Then if you take the treatment in these individuals, small cell carcinoma, surgical resection will not be useful because small cell carcinoma is a highly aggressive tumor. It spreads, it metastasizes. So these patients, they will be requiring chemotherapy, and the chemotherapy that is given in case of small cell carcinoma, that includes drugs like the etoposide plus cisplatin, right, or carboplatin has to be supplemented. That is in case of small cell carcinoma. Whereas in non-small cell carcinoma, it is the surgical resection which is best, because most of these non-small cell carcinomas, they are localized, so they can undergo surgical resection. But if at all, if they metastasize, then in such case the chemotherapy should be given. And this chemotherapy in case of non-small cell carcinomas, that includes supplementation of the paclitaxel or plus carboplatin. Right, paclitaxel plus carboplatin, that should be the chemotherapy in case of non-small cell carcinomas. So this is in detail about the bronchogenic carcinoma in a form of a quick revision.